actually has 2 written into his contract. It's used in tennis by Rafael Nadal, and it's currently used widely in veterinary practice. Supervet has in terms of what it does, it's the use of various wavelengths of light therapy to penetrate at various depths. And why we find it beneficial is that it can be used in a short period of time. So our sessions usually last about 10 minutes. What can it be used for? So K-laser is used, or the premise of K-laser is that it helps to accelerate tissue repair by improving muscular activity and vascular activity. It also helps with wound healing, reducing fibrotic tissue formation. It also has an anti-inflammatory effect, activates lymphatic draining, and also has a pain relief effect as well. We also want to think about the safety of K-laser. It is safe. If you look at this diagram, in about an hour, you would receive 800,000 joules of light energy on your back if you were out on a sunny day, whereas K-laser, 10 minutes of it in the same area would be about 21 joules of light energy, so we know that it's safe. Whilst K-laser does improve the kind of movement and the vibration of cells, it doesn't ionize them like X-rays, gamma rays, or ultraviolet rays. So the current evidence base. There's not much in terms of human evidence out there, as it's mostly used in the veterinary practice. As a therapist, obviously, we're often taught to be skeptical of the use of electrotherapeutic modalities, but I'll walk you through some of the evidence that's out there. So currently, there is quite good evidence out there in terms of how K-laser can help with wound healing. I mentioned earlier that it stimulates the healing process by improving cell proliferation and increasing microcirculation and oxygenation of tissues. There's a couple of trials that I'm going to talk about in a little bit of detail. There was one trial in 2004 whereby K-laser was used on participants that had 2 deliberate wounds inflicted on their skin with a standardized instrument. One cohort of patients was administered K-laser, and the second cohort was administered a placebo effect on one of their wounds each. The course of treatment was 10 days, and it was found that in the intervention group, the wound that was treated healed faster than the placebo group, but it was also noted that the untreated wound also healed faster in comparison to the untreated wound of the placebo group, so one could surmise from that perhaps it has a good effect on surrounding tissue as well. Further to that, at the Guy's and St Thomas's Diabetic Foot Health Centre, it was used to treat diabetic foot ulcers in a very small cohort of patients. So there were 11 patients. 5 patients were treated with laser once a week pre their standard care, and the remaining 6 patients were treated with standard care, which is specialist dressing, offloading, and antibiotics. They were treated over the course of a 12-week period. 4 out of the 5 patients that had laser therapy, their ulcers had healed by the end of that duration, in comparison to the control group, whose ulcers still existed at the end of that 12-week period. I'm going to show you a picture of someone's foot, so if you've had your breakfast, I'm sorry. I'll keep it quick. But that is just after 3 laser sessions, so once a week for 10 minutes before their standard care, and that's the impact. Following on from that, there's some evidence about how K-laser can assist with grip strength. A trial was conducted in 2017 by Barbosa et al., and there were 2 groups of patients, well actually 3, 45 patients. One group was administered K-laser at a depth of 904 nanometers, One group was administered it at 660, and the third group was treated with a placebo. They all underwent the same exercise intervention, which was the Oxford protocol for grip strength, which is 10 reps at 100% effort, 10 reps at 75%, and 10 reps at 50%. They all had their intervention twice a week, and this went on for 4 weeks. At the end of the trial, it was noted that the patients with K-laser at the depth of 904 nanometers had statistically significantly improved grip strength versus the 660 nanometer group and the placebo group. It can be suggested that the depth also therefore is important. Lastly, we also looked at tendinopathies. There was a systematic review done in 2015 where it was found that K-laser can have a positive effect on patients that, in terms of their inflammation of their tendons, their pain, and the restoration of their function in conjunction with their standard exercise protocol. Following on from that, I have a little bit of data about fractures. There was a study in 2014 by Chan et al, and they treated a group of patients with laser therapy, and it was at the depth of 830 nanometers. 2 groups, so it was 50 patients in total, and they had laser 3 times a week for a duration of 5 minutes at a time. For 5 weeks, it was found at the end of the trial that the laser group had significantly improved pain, and that their patient-reported outcome measures were also significantly improved versus the control group. It was also found radiographically that cortical bridging was significantly better in the intervention group. Last but not least, there was a trial on K-laser in carpal tunnel for mild to moderate population. It was found that K-laser significantly improved their grip strength, patient-reported outcome measures such as pain, functional scores, and also the distal motor latency of the median nerve. This is just a picture of K-laser being used in hand fractures at tendonitis. So how have we used K-laser at Geyser tendonitis? So initially, when we came across the modality, we wanted to use it for patients that we had struggled with, that had long-term chronic problems and didn't seem to be responding to anything else. But we started to look at the fact that in the animal population, it was very well used in the healing of acute injuries, and we started to explore how we could use it as an adjunct to our surgical patients or patients with very acute injuries. We found that it was helpful with wound healing, the treatment of edema, and bone bruising by cumulative effect. And we worked closely with K-laser based on the presentations that we have in our patient cohort to develop specific hand treatment protocols. Our K-laser is administered by 4 hand therapy assistants, so they're all trained in the use of K-laser, the different protocols, and also they have to complete an exam before they're able to carry out K-laser sessions. We also found that because it was very beneficial for acute patients, we wanted to explore it a bit further in terms of using it for flexors, which I'll go on to talk about a little bit later. Another thing that was also found was that patients seem to really like K-laser. The DNA rate for K-laser is currently 5% versus 12 to 14% for follow-ups in hand therapy. This slide just shows PRWHE for 22 patients that had a varying range of acquired conditions, and this just shows how their PRWHE scores improved over the duration of their K-laser sessions. Prior to K-laser, they had about 16 months of therapy and we started to stagnate in terms of their results. These patients had an average of about 13 sessions of K-laser each. There were 22 patients, and this is how they improved over the course of that intervention. So the next steps, as I mentioned earlier, we noted that K-laser is particularly beneficial in the acute phase, and we wanted to look at how we can use it as an adjunct to the treatment of flexor tendon repairs, particularly zone 2. We know that zone 2 flexors tend to do badly in terms of the evidence that's out there, and we wanted to find out whether or not by standardising the protocol and by this prospective study, patients could ultimately improve their outcomes in terms of flexor tendon repairs. Roughly at Guy's St Thomas's, we repair about 250 flexors a year, and the primary question would be, does K-laser help to improve the outcomes of total active motion, fixed fractures deformities, rupture rates, return to work, functional scores and pain? So we would be looking at doing, obviously taking this to ethical approval. We're looking at a sample size of about 35 patients each for statistical significance. In terms of the treatment protocol, they would have 2 sessions a week. They would have 2 sessions pre their therapy appointments for K-laser, and the control group would have 2 sessions of hand therapy a week. We would then look at their primary outcomes at 2 weeks, 6 weeks and 12 weeks, which models what we're doing currently, and they would all be treated obviously with the same treatment protocol. So to conclude, we know that K-laser is safe. It delivers energy at the varying depths that can have therapeutic benefits. At Guy's St Thomas's, we found that it's extremely beneficial in managing acute injury and wounds, and we aim to conduct some research to kind of bridge the gap between the theory of what K-laser is and actually the actuality. So thank you.